I am Dr. Manish Dhawan and I am working as a senior consultant orthopedics at Sir Gangaram Hospital, New Delhi. I also work in the same institute as Professor of Orthopedics at Gangaram Institute of Postgraduate Medical Education and Research, and I am also the teaching coordinator at Gangaram Hospital. My special interests include limb reconstruction for complex trauma, malunions, non-unions, limb lengthening for single limb shortening and short stature, including achondroplasia. Adult limb deformity correction. I frequently use spatial correction like hexapod, the German fixator, SUV, the Russian fixator, Taylor spatial frame, the American origin, and DefFix, our own Indian fixator. And pediatric limb deformity correction also interests me, including congenital anomalies, clubfoot, hemimelias, genu valgum, varus, and congenital zoodarthrosis tibia. I have 25 years of experience in applying Ilizarov, LRS, and doing spatial correction. And I've done my training in Ilizarov surgery at various places. In India, I've done in Mumbai, Miraj, Vellore, and done my advanced deformity correction fellowship at Vancouver, Canada, Kurgan, Russia. My learning also included attending the Baltimore limb deformity courses couple of times. I hope my lectures will be useful to you. Today we'll be discussing about the management of distal tibial fractures, including Pilon by external fixator. We will do this with Ilizarov and limb reconstruction system. Now, for this lecture, I have done also a lot of research from many books, and few are so. Transosseous osteosynthesis by G.A. Ilizarov, operative principles of Ilizarov Asami group, treatment of fracture non-unions and bone loss of tibia with Ilizarov method by M.A. Katani, advances in Ilizarov apparatus M.A. Katani, basic techniques of extremity reconstruction by Mehmet Kakmak, advanced technique for extremity reconstruction Mehmet Kakmak, limb lengthening and reconstruction surgery by Svetlana Rosenberg, and M.A. Katani atlas for insertion of transosseous wires and half pins, Ilizarov method. Now, Ilizarov method is useful in treatment of severely comminuted distal tibial fracture, especially tibial pilon fracture with skin problem. It has become a treatment of choice in selected cases of open fractures with severe soft tissue damage, blister formation, skin degloving, where internal fixation should be avoided. It can be performed in acute stage of blister formation or severe swelling, as wires and pins help in decompressing the compartment. Sometimes in acute stage, when there is blister formation or skin problems, you cannot apply the plate. So you have to wait for 2 to 3 weeks before you do the surgery. So in Ilizarov is one modality where you can do the surgery in acute stage immediately after injury. It is treatment of choice for infected non-unions. Now, mechanism of injury. Now, there are two mechanisms of injuries. One is the high velocity trauma and other one is the low velocity trauma. So first we will see high velocity trauma. Distal tibial fractures, especially pilon fractures, are most common caused by axial loading, high energy impacts such as fall from height, motor vehicle accident, leading to higher degree of disruption of articular surface and soft tissue affections. Ilizarov and LRS is a very useful modality in their treatment. Low velocity trauma, it may be caused by shear loading, rotational or low energy impacts, less degree of disruption of articular surface, seen commonly in osteoporotic bones. Internal fixation is a useful modality in their treatment. Now, mechanism of injury, if there is the foot is plantar flexed down, so what happens, the impact goes up and it can cause a posterior malleolar fracture. Now, if foot is in dorsiflexion, you get a fracture at the anterior part, and if the foot is in neutral position, it causes a disruption of whole condyle. You can see the both anterior and posterior condyles. Now, radiology, we take X-ray in two planes, AP and lateral, 45-degree oblique view if CT scan is not available. CT scan is a very useful in planning for articular reconstruction. MRI resonance imaging is rarely reused, and angiography is indicated when there is a vascular injury. Now, classification of distal tibial fractures. Now, the most common fracture classification used is Rudy and Algover classification. It is type 1 is a simple fracture of distal tibia with minimal articular displacement. So, you can see the articular surface has escaped. Type 2, it is a moderate fracture dislocation of distal tibial articular surface without much comminution. Yes, there is a fracture, but comminution is less. Type 3, there is a substantial comminution of distal articular surface with impaction of metaphyses. So, there are multiple pieces. You can see the typical high energy Pilon fracture. Now, AO and OTA classification of distal tibial fracture is also used. It is of different varieties. 43A is extra articular fracture. So, A1 is simple fracture. You can see this is just a simple fracture. A2 is a wedge fracture. A3 is a complex fracture, but the articular surface is escaped. Now, coming to 43B is a partial articular fracture, and B1 is a pure split. You can see this is the split. B2 is the split with depression. So, there is a split also, and there is a, you can see there is a depression also here. And B3 is multiple fragmented depression. So, multiple fragments have gone. So, this is a complex fracture. Now, type 43C is a complete articular fracture. C1 is articular simple. You can see there are multiple fragments, but there is no invagination or depression of the fragments. And C2 is articular simple, metaphyseal multifragmentary. So, this has many pieces. And C3 is a articular multifragmentary. So, you can see articular multifragmentary with disruption of the invagination and depression of the fragment. Now, CT-based classification is also there. It is divided into 4 types. Now, type 1 are all non-displaced fractures. Type A1, 1A and all extra articular types are B. So, these are the type A fracture. Type 2 are displaced 2-part fractures. So, this group is divided into 2 subgroups. Type 2S, the fracture line is in sagittal plane. So, it is a fracture line which goes into sagittal plane perpendicular to the intermalleolar axis and separate the pilon in a medial and lateral fragment. So, it makes pilon into 2 fragments, medial and lateral. Type 2F is a fracture line in frontal plane. You can see this line goes in a frontal plane parallel to the intermalleolar axis and separates the pilon in anterior and posterior fragments. So, you can see this is the anterior and posterior fragments. Type 3 is displaced 3-part fracture. Type 3S is the main fracture line lies again on the sagittal plane, and type 2F the fracture line is in frontal plane. Type 4 are displaced 4-part fracture, highly comminuted articular fractures. This type may be divided according to the zone of comminution and contains a fragment known as die punch fragment. So, die punch means the fragment has gone inside, it has gone up. So, this is the classification. Usually the classification have an academic value. Now, joint comminution pattern. So, we have to understand when we have to reduce the pilon fracture, you have to see what is the usual pattern of joint disruption. So, if you see that there are typically 2 main fragments, which is the anterolateral fragment or the talus or chaput fragment. So, this is the talus or chaput fragment. This is basically on the anterior side, and posterior fragment is also known as the Volksmann fragment. This is on the posterior side. These are the 2 main big chunks of the fracture because it is protected by the lateral malleolus on the lateral side. So, lateral malleolus protects, so the fragments which are nearer to the lateral malleolus are basically 2 big fragments. Main comminution is seen in the medial fragment. So, this is the medial fragment. So, it is a anterolateral fragment is talus or chaput fragment, posterolateral fragment is Volksmann fragment, and comminuted medial fragment. So, these are the typical pattern of fracture lines. Now, coming to the safe zones, because if you have to fix it with Ilizarov or LRS, you have to understand that where you have to put the wires. So, usually the leg is divided into 6 cuts. So, cut 1 is at the proximal end and cut 6 is at the ankle. So, the rings are usually put at cut 1, cut 4 and cut 6. Now, coming to cut 1. So, reference wire is the first wire which is put in transcondylar plane. This is anterior to fibula. Now, additionally, optimum fixation can be done by putting 2 half pins anteriorly at an angle of 60 to 90 degree. A wire can be used to transfix the proximal tibiofibular joint. In case of lengthening, you have to engage fibula also. Now all these wires and pin have to be put 13 to 15 millimeters distal to articular surface of tibia. Now coming to cut number 2, the half pin is inserted perpendicular to subcutaneous border of tibia on the medial aspect. So it is basically skin and bone, there are no muscles, you can put it directly. The wire is then inserted slightly obliquely to the transverse plane of the tibia to engage its widest portion. So this is the standard assembly for the cut 2. Coming to cut 3 is similar to cut 2, so there is no difference. Cut 4 is also similar, one wire and one half pin. Cut 5 is also similar, one wire and one half pin. Now coming to cut 6, this is the most important because this is the region of the pilon fracture. So a distal tibial reference wire is used, which is direct wire medial to lateral side. So this is basically the wire, this is the reference wire. It is parallel to the ankle joint line. The fibular stabilization takes place through lateral oblique wire directed from posterior lateral to anteromedial. So this is the tibiofibular wire. Additional stabilization can be achieved with a wire direct from anterior lateral to posterior medial. So this is the third wire, and a stabilizing pin can be put in this fashion. So in the distal part you can have a multiple wires and pins, and these are all basically put 13 to 15 millimeters above the ankle joint. Now coming to the application of Ilizarov fixator. So step 1. So you can see the red lines, the irregular line, this is the fracture site. So this is the basically a sawbone and a placed in AP and lateral view. So first step is you give traction. Now once you give the traction, all these fragments, they will come into alignment because of ligamentotaxis, and 80 to 90% reduction can be done. If is still required, then what you do that you take a joystick of 3 millimeter K wire and you can put the fragments in position. Once this is done, you can even hold these fragments with a guide wire, and then you can put cannulated screws on. Now once this is done, the assistant keeps the leg in traction. You pass 2 to 3 wires in the proximal fragment at the level of fibular head, and then you apply the first proximal ring. These wires used are the trocar wires because it is in the cancellous bone. Now second ring is put in diaphysis. This is with the bayonet wires, 2 to 3 wires, or a half pin can also be used for additional stability, and then you put the second ring. Now the ring number 1, the proximal and the middle ring are connected by 4 threaded rods. So this is the assembly, and you have to tension the wires. I'm not showing tension in the animation, so you have to tension them. Then you come at the pylon side, you use the olive wires. 2 to 3 olive wires can be used easily, which I have shown you previously also, and then you apply the lower ring, and then you connect the second ring with the third ring, and the traction is kept on by the assist. Once this is done, you tension it, and then you come to the foot ring. You put 2 trocar wires in the calcaneum, and you can even additionally put 2 shank pin from the posterior side. So you apply 5/8 ring at the calcaneum, and these are also connected by 4 threaded rods. Now coming to the foot frame, which sometimes is necessary because if you want to prevent the drop of the forefoot. So what you do that you put a wire, single wire, in such a way that the wire basically impales the first and fifth, because foot has an arch. So if you put a wire impaling all the 5 metatarsals, also then it causes problems. So you just put it in the first and fifth, and you apply a half ring, and then you connect this with the middle ring in the tibial shafts in this way. Now coming to method of reduction and fixation of intra-articular fragments in the pilon case of pilon fractures. So this I have already explained you the different fragment, what is the T-lux fragment, what is the Boltzmann fragment, and the medial fragment. So now you have to fix them. So traction is given by the assistant, and you have used joysticks to align put the fragments in a most acceptable position. So what you do that you put a guide wire from T-lux to Boltzmann fragment, which is on the lateral side, and then over the guide wire you put the cannulated drill bit, you drill it, and then you put a screw over the, and once you tighten the screw, these fragments get reduced. So you now have a big chunk on the lateral malleolus and 2 main fragments. So it is now secured. Now what you do that you put a wire, olive wire, from the fibula till the medial side. So this will fix the whole lateral fragment, and then only remaining is the middle fragment. So once this olive wire is poured, then you hold it with the wire fixation bolt and tension it. So this is a solid fixed fragment. Now you have to fix the middle fragment. So you put a olive wire, and the olive is towards middle side, from middle to lateral side, and then you put the wire fixation bolts and tension it. Once you tension it, the fracture closes. Now you put an additional olive wire from the middle side and tension it. So this gives a very solid fixation. So now we come how we apply the LRS. So this is your saw bone. This is the fracture with the crooked red lines. First step is, as with Ilizarov, you have to give traction, and once you give traction, the fracture fragments they align. Now LRS can only be applied when the fracture is up and it does not involve intra-articular fragments, and at least 3 pins can be put in the distal fragment. There should be no fracture. Basically, this fracture is at the junction of upper 2/3 and lower 1/3. So the joint line has no fracture. Now once this is done, then you take the LRS rail. Now you have to put 3 templates over it. Templates are the white structure which guide us to put the pins. So once the template is put, now we put the sleeves, and you drill the topmost. Through the topmost sleeve, drill this is the first hole, and then what you do, you drill at the last slot. So once this is done, you put pins at the the topmost and the lowermost. So now this LRS is stable now. So we have fixator up and bottom, and it is now stable. Now it is the time to fix put the other pins. So you drill the second hole. This is the second. You drill the third one. This is the fourth one. This is the fifth one. This is the sixth. So once the drilling is done, you put shank spin in all the drilled holes, and once this is done, you remove the templates and put the end clamp at both the ends and the middle clamp at the middle. And once this is done, then you put your CD unit. This is the CD unit. This is the compression distraction unit. So CD unit is applied. If you could see on the lateral view also, this is the CD unit. So basically this helps if you have to compress or distract the fracture. Now coming to case 1, we have learned about how to apply Ilizarov, how to apply the LRS frame. Now this is a 31-year-old male. He had a road traffic accident riding a scooty in November 2021 in Goa. Sustained Pilon fracture dislocation left ankle, and was given slab by local doctor and was airlifted to Delhi. When he came to Delhi to us, there was a very severe swelling, and there was a full thickness damage to skin over the middle malleolus. Ilizarov fixator was applied after reduction, and minimal fixation with cannulated screws were done. No flap surgery done, and skin was left to heal after plastic surgery consultation. So this was the whole situation, and you can see a big full thickness defect there. A problem lesion in the skin. So this was his X-ray and the CT scan. So this basically gives us the planning. The ankle was also dislocated, and for 2 days this ankle remained dislocated. So what we did, that in fixation of this Pilon fracture, the most important thing is that you have to first fix the fibula. So what you do, that you put a intramedullary Ilizarov wire. So this is the most important step. Once you reduce that fibula, the tibia automatically falls into the position. The joint will also fall into the position. This is the first step. Once this is done, then we put the cannulated screws on fixing the tibia. And once this is done, so we have used 2 cannulated screws from middle side and 1 anterior posterior cannulated screw to fix the posterior malleolus. Once this is done, we apply 3-ring frame, and then we put an additional 5/8 ring at the foot to hold the calcaneum. And you can see the final Ilizarov application. So this is our patient with the frame, and you can see that he is bearing weight. He is standing and there is no problem. He is bending his knee also, and you can see his video how he walk. He is walking over the frame. So benefit is that in Pilon fracture, the distal tibial fracture, you can make the patient put weight, walker, partial weight bearing. Now this is a picture after removal of the frame, and you can see his ankle movements. How well is he doing? So coming to case 2, this is a comminuted compound distal tibial short fracture, and we had used LRS. This is a 21-year-old male sustained comminuted fracture lower third tibia and fibula after fall from motorbike as a Pilon rider. He had medial skin damage and LRS was applied after minimal fixation with cannulated screws at the fracture site. So you can see the skin is damaged here. So we did not take any chance, and this was his fracture. You can see there is a butterfly fragment also. So what we did that we reduced the fracture with traction. We put two cannulated screws to hold the butterfly fragment and we applied our frame. So this is the patient's clinical picture with the LRS frame. You can see his knee movements also, putting full weight, no problem. So this is after removal of the frame, and I've also removed the cannulated screws, and you can see his knee movements, almost 90 degrees of movement. Now coming to case 3, this is a 51-year-old patient had a run over by tractor trolley after fall from a motorbike. At first stage, debridement, removal of devitalized fragments done, and application of universal external fixator was done. We did not apply Ilizarov at the first stage, and usually we do not apply if you have to do any skin flap. So latissimus dorsi flap was done by plastic surgeon later on to cover the skin defect, and Ilizarov fixator was applied and bone transport done after proximal corticot. So you can see how bad the wound is. It's totally contaminated, the bone is exposed, and this is the whole picture. Bone was exposed and also it was devitalized also. So at first we put a normal universal external fixator. The whole fragment was excised. We put an intramedullary rod in the fibula. Also we put a second alignment wire in the tibia. So this is just to guide the fragment, the transport fragment down, because the distally there was a very small part of tibia, the Pilon fragment, and we did a proximal corticotomy. You can see the proximal corticotomy. This was done and the fragment was transported, and this wire is guiding it down. So transport is going on well. So you can see a very good transport happening here, and it has docked and it has caused union at the transport docking site. You can see the picture of patient with the frame. You can see his knee movements, and this is his final x-rays with the good regenerate which has totally consolidated, and you can see there is a union at the docking site. This is the patient after removal of Ilizarov frame. You can see a very bulky latissimus dorsi flap. This can be reduced later on by the plastic surgeon. Now coming to case 4, this is a 41-year-old male had a motorbike accident, sustained multiple fractures right tibia. Distal tibial fracture had a compound wound. Debridement of wound was done, an intermedullary Ilizarov alignment wire was put, and proximal fracture stabilized with intrafragmentary cannulated screws and Ilizarov fixator applied. So you can see there is a small wound. This is a very small wound, but what is happening here? There was a fracture here, there was a fracture here, there was a fracture, and there was also split which was basically going down, which is not very visualized in the small x-ray. And you can see if you have to apply a plate, there is a huge plate which we have to apply. So what we did that we just put an intramedullary wire to align all the fragments together, just applied cannulated screw at the proximal fragment, the anterior posterior cannulated screws, and just applied the frame. No opening, no cutting. This is a minimal invasive technique. So we have used the Ilizarov fixator to fix this thing. You can see patient with the frame, you can see his knee movements and see how well it is fixed, and with a very minimal interference. And if you have to apply plate, a huge plate, you have to open almost the incision will be as long as the full length of tibia. So you can see his knee movements. Now coming to case 5, this is a 51-year-old overweight female, sustained close fracture lower third tibia and fibula. She was crossing the road and had a run over by motorbike. So internal fixation was done by anterior lateral plate and later reinforced by a small locking plate, and went into non-union and referred to us for Ilizarov fixator. So this was a simple looking benign fracture which was ideal for internal fixation. So firstly, anterior lateral plate was applied, the hockey stick plate. But surprisingly, there was no plate fixation at fibula. So this plate went loose, the fracture went into varus. Then the surgeon applied a small plate on the other side to reinforce it and reapplied the screws and bone grafted it. But what happened that, and he did a fiblectomy also that time. So this was also done. But the fracture went into non-union. So what we did that we excised the whole fragment because it was a non-union, twice it was operated, bone grafting has also failed. So you cannot make that fracture unite by any means. So you have to excise the fragment, and we did a proximal corticotomy. This is the proximal cortical, transported the fragment. So this is the patient's Ilizarov frame. You can see this whole fragment has come down. This is the regenerate, and you can see patient with after removal of the frame. You can see her leg after removal of the frame. Now coming to case 6, this is a 60-year-old patient operated last year with a grossly comminuted pilon fracture. Patient had diabetic neuropathy with no sensation in the forefoot and decreased sensation in the hindfoot. There was high chances of Charcot joints. Skin was adherent to fibula, osteoporotic bone. Internal fixation plate because of the skin condition would have caused a problem. So minimal fixation with cannulated screws, K wires in fibula and Ilizarov fixation was done. So this was the fracture. You can see a pilon fracture, bad fracture. You see the skin condition, bad skin. He did not have sensation also, so plating was avoided in this situation. And first step is that traction was given to align it, and then a wire in the fibula was put. So once you put a wire in the fibula, around 80% of fracture in the tibia, it comes into the position. Cannulated screws were put, and then medial malleus tension band wiring was also done, and you can see the patient in the frame, and it is well fixed. So this is a minimal invasive technique. It comes very handy when you cannot do any internal fixation. Now coming to case number 7, this is 65-year-old female, has a grossly comminuted closed pilon fractures, and she had a fall from stairs. Patient had uncontrolled diabetes with coronary artery disease. She was operated elsewhere, and K-wire fixation of fibula and plating tibia was done. Developed dehiscence of the wound, exposure of plate and infection. Plate from tibia was removed and Ilizarov fixation was applied. So this was the fracture initially. This is a preoperative X-ray. You can see a plate was put in the tibia on the middle side and a fibular wire was put. But what happened, that plate got exposed and there was a discharge from the wound. So it became infected. Now once this happens, Ilizarov is one of the modalities to tackle this situation. So plate was removed, the fibular wire was retained, and Ilizarov frame was applied. So this was the situation post-op, and this is the patient with the Ilizarov frame. You can see the patient is walking comfortably on Ilizarov frame. This video is shot just before the removal of frame. So thank you very much. I hope that quite a good understanding of application of Ilizarov is in pilon fracture explained to you. You must have understood. And also LRS application in a distal tibial fracture where the joint is not involved. So that becomes a very handy situation, because we encounter this every now and then when there is a compound fracture or skin condition is not good, because most of the pilon fractures, they are high velocity injuries. They can be high velocity injury with blister formation. So this Ilizarov and LRS becomes very handy. Ilizarov is for pilon fracture, LRS is for the fracture above where the joint is not involved, and at least 3 pins can be passed in the distal fragment. Thank you very much. Thank you.